2024 questions. Yes. All right. Boys and girls, I am waiting for you to respond. And we are going to start with the question 1. And I hope all of you are already the part of DAMS-Delhi official Telegram channel. And yes, you need to let me know. Okay. All right. Now I can see myself. All right. So boys and girls, so this time the paper was pretty basic yet very conceptual. So this time there were approximately 13 MCQs which were asked, and these MCQs were basic yet conceptual. Now out of these 13 MCQs, so one MCQ was an integration with that of anatomy, while most of the MCQs, the topic which was asked, most often asked topic in your November INICET exam was that of retina. So this is not the general pattern which is followed. Sometimes they may ask more of glaucoma, sometimes they may ask more of lens, but this time they have focused on the retina. So what does it tell you? It tells you that you cannot simply rely on a single topic. You don't know which topic they are going to ask next. Yes. So now going over to the discussion, I am quickly going to discuss the MCQs and will try to touch the near points of the options which were provided in the exam. All right. Now the first question is, which of the following is true regarding OVDs used in cataract surgery? What is the full form of OVD? It is oculoviscosurgical device. Now OVD is of two types. One is your dispersive, one is your cohesive. So cohesive and dispersive. Now the dispersive OVD, when you put it inside the eyeball intraocular, it coats the endothelium of the cornea. What is its benefit? It prevents the endothelium damage. In which steps you are operating, you mistakenly hit the instrument at the back of the cornea. It provides cushioning effect. Or you are doing phacoemulsification, so there will be chattering. Chattering is when there is flying of the lens particles in the anterior chamber while undergoing phacoemulsification. So in that case, the particles may hit at the back of the cornea, damaging endothelium cells. So dispersive OVD helps in that. What is the function of cohesive OVD? So cohesive OVD, it actually maintains the anterior chamber. So when you are inside the eyeball with your instruments, you require to have the proper depth of the anterior chamber, na? Otherwise you may hit your instruments at the back of the cornea, or you may even hit on the surface of the iris, or you may damage any other intraocular structure, which nobody would want that. Yes. So these are two OVDs, cohesive and dispersive. Yes. Now coming over to the option. So whenever you read the question, you have to analyze, you have to process what the examiner is asking about. So here the examiner is asking about OVDs. If you don't know OVD, it will be difficult for you to answer this question. Yes. Okay. Pehli cheez, first thing, first option is it maintains anterior chamber in capsulorhexis and IUL implantation. Of course, they have generalized the usage of OVDs. So cohesive, dispersive. So cohesive is used to maintain the anterior chamber. and also to implant IUL. Yes, so this is the right option. Yes, it can be left in the eye because this is inert. This is highly viscous substance. You cannot keep it in the eye because post-operatively it will lead to raised intraocular pressure and the patient may complain of severe pain in the eye post-operatively. So you cannot do that. Yes, so this is incorrect option. And then corneal epithelium is damaged. I just told you that it helps in preventing the damage to corneal endothelium. They are talking of corneal epithelium is damaged. It has nothing to do with corneal epithelium. Yes, this is also incorrect option. Then SF6, which is sodium hexafluoride, and perfluorane are commonly used viscoelastic substance. These are not viscoelastic substances. These gases are used in the treatment of retinal detachment because these gases are lighter than vitreous humor. They will rise up. Suppose this part of the retina is detached, it is going to rise up and it is going to push back the detached part of the retina. Yes, so the answer is clear cut, which is A. It maintains anterior chamber in capsular excise and IOL implantation. In intraocular surgery, not only capsular excise and IOL implant, even when you are doing phacoemulsification, so you need to put the dispersive OVD from time to time because you don't want the lens pieces to fly in the anterior chamber and hit the back of the endothelium. Yes, and may damage it. Yes, okay. Now the next question was, which of the following is seen in diabetic retinopathy? So for that, the diabetic retinopathy topic should be crystal clear in your head. Is it understandable? Okay. Now, what is retinoscheisis? You know what is retinal detachment. Retinal detachment is the detachment of the neurosensory layer with that of the retinal pigment epithelium. Retinoscheisis is if there is detachment between the layers of neurosensory layer. So inner 9 layers, which are collectively known as neurosensory layer, if it gets detached from the retinal pigment epithelium, so that is retinal detachment. But if there is separation of inner 3 layers from the 6 layers, 6 combination layers, so that is retinoscheisis. Inner 5 layers from the 4 layer. So it is like this. If there is intra neurosensory layer detachment, you call it as retinoscheisis. I hope now it is understandable. So of course it has nothing to do with specifically diabetic retinopathy. So this is not the correct option. Next is tractional retinal detachment. Tractional retinal detachment is associated with neovascularization. Why? Because when there will be neovascularization will happen to be on the inner surface of the retina. Now in neovascularization, there is formation of fibrovascular membrane. Now this fibrovascular membrane eventually contracts. When it will contract, it is going to pull the neurosensory layer from the underlying retinal pigment epithelium. That is tractional retinal detachment. And you know, in diabetic retinopathy, the early stage is NPDR, which is non-proliferative diabetic retinopathy. The late stage is PDR, which is proliferative diabetic retinopathy. And why it is known as proliferative diabetic retinopathy? Because there is formation of new vessels. Why there is formation of new vessels? Due to secretion of VEGF, 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 VEGF. Yes, vascular endothelial growth factor. So this is the right answer. But as I always say, always try to reach to the answer by mode of exclusion, not by pointing that answer there and then. Yes. Okay. What is posterior staphyloma? Posterior staphyloma is weakening of the outer coat of the eyeball, due to which there will be bulging with the incarceration of the uveal tissue underneath. Posterior staphyloma is commonly seen in high myopia. So myopia and posterior staphyloma has got no association with diabetic retinopathy. Yes, so the answer is pretty straightforward. It is tractional retinal detachment. All right. Next is, which is not present in inner segment of photoreceptors. This was one question which was integrated with that of anatomy. So I have put up a pic of rods and cones, inner segment. You can actually appreciate that there is presence of mitochondria. Similarly, there is presence of other organelles like Golgi bodies, like endoplasmic reticulum. But one thing which is missing is disc membrane. Yes. All right. So that was the answer. In this case, it is disc membrane. Okay. Pterygium can lead to, what is pterygium? Pterygium is elastotic degenerative condition of the conjunctiva. Most common site of pterygium is nasal. Why? Because when the light is coming from above, because most common etiological factor is UV rays. When the light is coming from above, it is striking the bridge of the nose, and from where it is getting deflected to 90 degree. When it gets deflected to 90 degree, the site which receives the maximum UV rays is the nasal conjunctiva. That is why there is elastotic degeneration of the nasal part of the conjunctiva, which leads to pterygium. So most common site is nasal site. Now when the pterygium is spreading over the cornea, it sends its roots up till superficial stroma. What is stroma? What are the layers of the cornea? A, B, C, D and E. A for anterior epithelium, B for Bowman's layer, C for corneal stroma, D for Descemet's membrane, and second D for Dua's layer, E for endothelium, in the same sequence that I have told you. Now it goes till superficial corneal stroma. When it goes till superficial corneal stroma over the surface of the cornea, so it leads to flattening of the x-axis of the cornea, because the pterygium is coming from here, so it will lead to flattening of the surface. If there is flattening of x-axis, flattening, that means the y-axis will be rather more curved, so it can cause astigmatism. Which astigmatism? More specifically, it will be with the rule astigmatism. Why? Because with the rule says that vertical curvature should be steeper than horizontal curvature. Done. Let's talk about other options. Corneal scarring or eye pain. Guys, please note, pterygium itself cannot cause corneal scarring, but when you'll operate the patient, you'll do the excision of pterygium. Then if it is going deep into the stroma, you will remove it. At that area, it can cause corneal scarring, but that is post-operatively. There, they have just asked about pterygium can lead to. So this cannot be the answer. Macular edema. Pterygium has nothing to do with macular edema. Purulent discharge. It is, I told you, it is elastotic degenerative condition, not an infective condition. So purulent discharge, no. Yes, I hope it is understandable. Now coming over to the next question. Which of the following is seen in fundus fluorescein angiography in microaneurysms? Now what happens is, normal pericyte to endothelium ratio in the retina is 1:1. That means if this is your endothelium, this is your endothelium, yes, so this is your endothelium. Each endothelium is surrounded by one pericyte, such that the P/E ratio is 1:1. But in diabetics, high blood sugar is toxic to pericytes, such that the ratio now becomes 1:3. It becomes 1:3. Now you tell me, one pericyte will be able to hold one endothelium efficiently, or one pericyte is able to hold 3 endothelium efficiently? Of course, one pericyte for one endothelium. But what if one pericyte is forced to hold 3 endothelium at once? It will not be able to hold that. So as a result, there will be development of microaneurysms. Microaneurysms are protrusions in the microvasculature. Now when you inject the dye in the antecubital vein, which dye? Sodium fluorescein dye. After 11 seconds, the dye will appear in the retinal circulation and you will take photographs with red free light. So you will see wherever there is bulging of the outer wall of the vessels, which you technically call as microaneurysms, you will see hyperfluorescent dots there. And I have shown you many times in my lectures the image. I have actually shown you the real video of FFA being done. So the answer is pretty straightforward. It is hyperfluorescence dots. Alright, coming over to the next question. Okay, which of the following is not derived by neural crest? Now you know that the eyeball is developed from prosencephalon. There is a part of the prosencephalon which is diencephalon. So there is protrusion of the optic stalk, two optic stalks from the prosencephalon part, which is diencephalon, on the lateral side. Then they move anteriorly. So there is this optic stalk. The distal part of the optic stalk gets converted into a round structure. You call it as optic vesicle. Now this optic vesicle, if this is one optic stalk and this is one optic vesicle, it gets converted into cup. You call it as optic cup. And there is anterior surface ectoderm, which invaginates and forms a circular structure inside the optic cup that later takes the shape of your lens. So lens develops from surface ectoderm, your previous year question. And you know, prosencephalon, diencephalon, these are neuroectoderm. Now optic stalk, which later forms optic nerve, is a part of diencephalon because it is the protrusion of the diencephalon, na? So that is also neuroectodermal in origin. Then there is formation of the cup, which later forms the retina. And you know there are 10 layers of the retina. So one of those 10 layers are retinal pigment epithelium. So that actually tells me retinal pigment epithelium should also develop from the neuroectoderm. Why? If you are planting guava tree, you are not going to get mangoes out of it. Yes. So tree means the root, the prosencephalon, diencephalon, optic stalk and optic cup. While these structures, ciliary muscle, ciliary ganglion, choroidal melanocytes, are derived from neural crest cells. Yes. Okay. Can you answer me one more thing? So there are two muscles, which is your sphincter pupillae and dilator pupillae. Can you tell me what is the derivative of sphincter and dilator pupillae? From which structure they are derived? Can you tell me? The answer to this question is not mesoderm, as most of you students will think, because we know na muscles are derived from mesoderm. No, sphincter and dilator pupillae are actually secreted by anterior non-pigmented epithelium of the iris, which is formed from the optic cup. But optic cup is neuroectodermal in origin. That is why, boys and girls, the sphincter and dilator pupillae are neuroectodermal in origin, not mesodermal. And ciliary muscles are derived from neural crest. Rest all the muscles in the body are derived from, you know it, mesoderm. Is it understandable? Yes. Okay. So other two structures, choroidal melanocytes and ciliary ganglion, they are derived from neural crest. All right. Now identify the layers of retina mark. So there was actually an animated picture which many students told me कि एक animated picture आई थी तो उसमें पूछा था. But my idea in this session is to make you remember the layers of the retina clearly. Now I will take your 2 minutes and I'll make you remember the 10 layers of retina just like that. Yes, can we start? Okay. The innermost layer of the retina is inner limiting membrane. And the second layer, which you already know, which you already have read, where in glaucoma, which gets damaged, that is your nerve fiber layer. Now, nerve fiber layer is connected to ganglion cell layer, which is the layer number 3, ganglion cell layer. Now, this ganglion cell layer has a nucleus which you can see. And there is another nuclear layer which is inner nuclear layer. Now you tell me, if two nucleus are to be connected, how they are going to get connected? With the help of a synapse. If they are going to get connected with the help of the synapse, the central layer which consists of synapse, that will be called as plexiform layer. So ganglion cell layer, inner nuclear layer, synapse, inner plexiform layer. Is it understandable? So that is our layer 4th and layer 5th. If there is inner nuclear layer and there is outer nuclear layer, of course, two nucleus, they have to be connected. How? Synapse. Outer plexiform layer. So outer plexiform layer is 6th and outer nuclear is 7th. If there is inner limiting membrane, then outside outer limiting membrane, layer 8th. And one layer which we have been reading since our school times, rods and cones, 9th layer. And the outermost layer, the 10th layer, which you already know, retinal pigment epithelium. It is this easy. So don't cram it. Just try to apply the concept. You may take 2-3 minutes extra, but trust me, you are going to remember for the rest of your life. So 7th layer, this is your 8th layer, this is your 9th layer, this is your 10th layer. Isn't it easy? Yes? Okay, now in previous year INICET, so if you recall, I had done one YouTube session on INICET images. So in that session, which was done just 2 days before the INICET exam on my YouTube channel, and I was told that 4 questions from that 1 hour session had come. One was the layers of the retina. Yes, you can revisit that session, but do become part of our DAMS-delhi Telegram group and do follow us on DAMS-delhi Instagram. So we keep on posting MCQs, we keep on interacting with you. So that is one stop destination for all of you. Yes, okay. So this is all about the layers of the retina. Yes, if you could understand these layers, any arrowhead towards any layer will come, you will be able to answer that. Okay, now what is the normal? So here just the options. I was told that there were arrows A, B, C, D, or 1, 2, 3, 4, and there was sequence that A is RP, B is ganglion cell, C is inner nuclear, D is outer plexion. So there was a sequence. So if you understand this sequence, so you can easily mark the answer. So I'm not giving any answer to this question because they had actually asked about the sequence. Okay. Now next is optic disc artery to vein ratio is. So artery is relatively thin, vein is relatively thick. So this is a single liner concept. In fact, the answer is henceforth 2:3. So artery lumen is narrower than vein lumen. Okay. All right. A patient came from a factory with a chemical injury to the eye. What will be the management? अब देखिए, the patient has come to you with chemical injury. Yes, of course, the patient will be coming to the emergency, or maybe he can walk with the eyes closed. So you cannot ask the patient to do visual acuity because something has gone in the eyes. It will be difficult for the patient. And if there is chemical injury, you have to flush out the chemical first and foremost. Yes, so you will not do visual acuity. And IUP measurement, that can be done later. That is the secondary examination part, not the primary examination part. First, you will do visual acuity, and then you can go on for slit lamp examination, and then ultimately you will go on for IOP measurement, because IOP measurement is done when the patient is on slit lamp. Yes, then only you will be able to do gold standard IOP examination, which is Goldman Applanation Tonometry, GAT. Yes, so not the IOP measurement. Now, one is you take history, second is copious irrigation. So just imagine, patient has come to you, Doctor Saab, something has got in my eyes. I would ask you, okay, what has got? So he will say, some chemical I was working. So I would not ask when did it go, where did it go, since how long, how you are feeling, what problems are you having. So I will not go into that depth. First and foremost is I'll quickly take a BSS solution, normal saline or maybe distilled water, and then I'll ask the patient to lie down in emergency bed, and I will start flushing the eye. I'll do copious irrigation with BSS, normal saline, because I need to flush the chemical as soon as possible. Suppose it is acid, suppose it is caustic soda, then of course I won't waste much of the time, because it can be detrimental for the ocular structures, or even if it enters into the intraocular structures. Yes, so I will simply go on for copious irrigation. Yes, this is what I personally feel. This is what I would do if I am sitting in the emergency. Yes, so this is the answer as per my belief. Okay, and yes, after irrigating the eye, then I will ask the patient, okay, कब हुआ, कहाँ हुआ, कैसे हुआ, आप क्या कर रहे थे, और ये आंख में कैसे चला गया, वर यू वियरिंग ग्लासेस. थोड़ा सा पेशेंट को डांटेंगे भी. अभी रिसेंटली मेरे पास एक पेशेंट आया था, and he was working in a liquid plastic industry, and he was just he was opening the cork of a giant vessel which had molten plastic, and it bursted. So he had got the plastic into his eyes. So the moment the patient came, there was plastic all over his eyes and face and everything. The moment he came, I immediately asked the patient to lie down, started washing his eyes, because you have got very less time, and this all thing happened 30 minutes back. The patient took at least 30 minutes coming from industrial area, phase 1 Chandigarh, to sector 8C clinic where I practice. Yes, so I feel that copious irrigation with normal saline should be the answer. Yes, okay. Now next is, what is the investigation of choice for Best disease? So Best disease, that there are retinal dystrophies. So if I talk about dystrophy of rods and cones, this dystrophy is known as RP, retinitis pigmentosa. After rods and cones, which is the next layer, it is retinal pigment epithelium. So Best disease and Stargardt disease, these are two diseases which are dystrophy of retinal pigment epithelium. Now in retinitis pigmentosa, the investigation of choice is electroretinogram, which is abnormal, while in Best disease the investigation of choice is electrooculogram, which is abnormal, while electroretinogram will be normal in Best disease. While in Stargardt disease, electrooculogram and electroretinogram both are normal in the beginning, but later electrooculogram will go abnormal. This is late in the disease. Yes, now you will ask, sir, what is electrooculogram? Electrooculogram is light peak over dark trough. So there are two waveforms. This is light peak, this is dark trough, LP dt. If it is more than equal to 1.85 or 185%, so that tells you that it is normal, and this normal 1.85 or more than 185% is your Ardern index. Ardern index. Then when you will say it is abnormal, if it is less than abnormal, I told you now, if it is less than 1.60 or 160%. So the answer is electrooculogram. It is the investigation of choice for Best disease, boys and girls. And do you know, in earliest phase of Best disease, the vision is not affected. There is egg yolk appearance on the macula. Quickly, I am compiling the important points. The signs are more than symptoms, and in late phase of Best disease, there is scrambled egg appearance. So, pehle egg yolk, then later scrambled egg appearance of the macula. And Best disease is autosomal dominant. It is seen in less than 6 years of age. While the other disease, Stargardt disease, there is symptoms more than signs. The vision is lost early in the disease. It is seen in less than 21 years of age, and it is autosomal recessive. You will see dark choroid on fundus fluorescein angiography, dark choroid on FFA. You will also see the beaten bronze appearance of the retina on fundus examination, and you will see the specks on the retina on autofluorescence, FAF, fundus autofluorescence. You will see the specks on the retina. Okay, all right. Now coming over to the next question. Which of the following leads to sudden bilateral painless loss of vision? So iridocyclitis is sudden painful loss of vision. It is usually unilateral, but sudden painful. So painful, you can eliminate this. Then glaucoma, specifically acute congestive glaucoma. It is sudden painful loss of vision again. Keratoconus, it is slow painless loss of vision. What about diabetic retinopathy? In diabetic retinopathy, you know, there can be tractional retinal detachment. There can be vitreous hemorrhage. If there is vitreous hemorrhage, there can be sudden, there can be painless loss of vision, and it can happen bilateral. So the answer is diabetic retinopathy here. Even tractional retinal detachment, it can be sudden, bilateral, it can be there, painless loss of vision. Some books mention that tractional retinal detachment is relatively not sudden. It is slow in onset. It is slow, slowly, there is loss of vision. While rhegmatogenous retinal detachment will be sudden, and exudative retinal detachment will be sudden. So tractional retinal detachment, so it may be overlapping. You can use it as per your convenience. It can be sudden, it can be slow, but yes, you can mark accordingly. Okay. A 1400 gram child was referred to ophthalmology department with leukocoria and calcification with history of prematurity. What is the probable cause? So leukocoria, what are the DDs of leukocoria? All four are the differential diagnosis of leukocoria. So there is no relevance of this history which is provided to us. Yes, but the relevant history in this scenario is your calcification. So out of these four conditions, which condition has calcification? Boys and girls, only one condition, which is retinoblastoma. If I talk about Coats disease is seen in less than 10 years of age, and there is exudation, and there is leukocoria, and it is more commonly seen in males. Done? Okay. Retinopathy of prematurity, you know, due to retinal hypoxia, there is neovascularization, which later leads to retinal detachment, tractional retinal detachment, due to which there will be leukocoria. Congenital cataract, yes, there will be leukocoria. Retinoblastoma, yes. But out of these 4 options, since they have asked specifically about calcification, so answer is pretty straightforward. It is retinoblastoma. Which of the following is seen in macular corneal opacity? So corneal opacity is of 3 types. How will you remember? A, B, C, D, E, F, G, H, I, J, K, L, M, N. So L for leukomatous, M for macular, N for nebular. How will you remember? Very easy to remember. See, nebular is mild, leukomatous is severe. When there is nebular opacity, so you are able to appreciate the iris fine details. Matlab, you will see iris crypts and furrows. You understand what is crypts and furrows? You must have undergone the iris scanner while applying for your Aadhaar card. So they actually take the photo of your crypts and furrows of the iris. It is believed that fingerprints of 2 people can be same, but the iris crypts and furrows can never be same, even of monozygotic twins. So if you are a fan of the Tom Cruise movie Mission Impossible, so you know in the very beginning, so there is one message which is displayed. So Mr. Ethan Hunt, should you wish to accept this mission, he presses button and then there is camera which will pop out from that, you know, that video recording or video recorder, and then his iris is scanned and then the message is read for 30 seconds and then there is one audio message. This message will automatically destruct in next 30 seconds and then there is smoke coming out of that, you know, tape recorder. So that is actually crypts and furrows of Mr. Ethan Hunt, which is scanned, based on which the message is displayed to him. I hope you have understood. Okay. Now coming over to macular opacity. In macular opacity, so you can see the iris, you can see the pupil, but the fine details are not visible. Fine details are not visible. While in leukomatous, you cannot see across the cornea. No iris is seen. No iris is seen. No view of the anterior chamber. Now you have understood. Now coming over to the question. So we are talking of macular corneal opacity. So both iris and pupil details are visible. No, that is seen in your nebular. Details of iris visible. No, that is seen in nebular. Both iris and pupil margins not visible. No, that is seen in leukomatous. Only pupil margin is visible. Yes, that means fine details are not visible, na? But overall the structure is visible. So you can say margin is visible, isn't it? Okay, so that is the answer. All right, so this was it. So these were the discussion of INICET November 2024 exam. And in case you have any queries, you can get back to me with this number I am sharing with all of you. This is my WhatsApp number. You can be a part of my Telegram group, that is Ophthalmology by Dr. Manish Chhabra. Ophthalmology by Dr. Manish. And you can also follow me on Instagram, that is I_Manish. And yes, I'll be available to help you and rise and shine. And yes, what else? Everything is good. Enjoy life, study, eat, play, have fun and repeat. Study, eat, play, have fun and repeat. Best wishes from my side. This is your ophthalmology faculty, Dr. Manish, signing off. Bye bye and take care.